North Africa. The summer of 1943. A soldier was carried into a field hospital outside Tunis, his leg torn open by shrapnel, the wound already darkening at the edges. The surgeon looked at the injury, then at the man's face. In any previous war, this would have been a simple decision. The leg would come off, the infection would spread regardless. But this time, the surgeon reached for something different. A small paper packet, a fine white powder, dusted directly into the wound. The soldier flinched. The surgeon said nothing. For centuries, infection had been the true killer of soldiers, not bullets, not artillery. More men had died from the wounds left behind than from the wounds themselves. Gangrene, septicemia, pneumonia, invisible armies that moved through every conflict, finishing what the enemy had started. The powder in that packet had a long chemical name no one on the front line bothered to learn. They called it sulfa. And for a few extraordinary years, it seemed like the answer to a question medicine had been asking for a very long time. What no one fully understood yet was the question it was also creating. The story did not begin on a battlefield. It began in a laboratory in Wuppertal, Germany. In 1932, in the research division of IG Farben, where a scientist named Gerhard Domag was conducting experiments most of his colleagues considered unlikely to produce anything useful. Domag was searching for a synthetic compound that could kill bacteria inside a living body without killing the body itself. This had been the central problem of antimicrobial medicine for decades. Antiseptics worked on surfaces, but bacteria inside the bloodstream, inside a wound, those were beyond reach. Working systematically, testing hundreds of dye compounds on infected mice, Domag found it in 1932. A red azo dye called Prontosil, when injected into mice infected with lethal doses of streptococci, kept them alive. The control group died. He did not publish immediately. IG Farben held the patent and wanted time to secure its commercial position. For nearly 3 years, one of the most significant medical discoveries of the century sat in a corporate filing. Then Domag's daughter Hildegard fell gravely ill from a streptococcal infection. With nothing else available, he administered Prontosil to her directly, in doses tested only on animals. She recovered. That same year, researchers at the Pasteur Institute in Paris identified what was actually doing the work. Prontosil was metabolized inside the body into a simpler compound, sulfanilamide. This molecule blocked bacterial folic acid synthesis, not killing bacteria outright, but preventing them from reproducing. The immune system could then eliminate an enemy that could no longer multiply. In 1939, Domag was awarded the Nobel Prize. The Nazi government forced him to decline it. He received the medal in 1947. 2 years after the war, his discovery had helped shape was finally over. By then, sulfanilamide had already travelled far beyond the laboratory and into the wounds of a war no one had yet imagined. Military adoption of sulfonamides did not happen through a single decision. It happened incrementally, then suddenly, as clinical results accumulated faster than anyone anticipated. By the late 1930s, sulfonamides were being used in hospitals across Europe and the United States to treat streptococcal infections, pneumonia, and gonorrhea, with results that were, by the standards of the time, remarkable. Mortality rates for certain bacterial pneumonias dropped sharply. Military medical planners took notice. The solution developed by the United States Army Medical Corps was both simple and bold. Sulfanilamide powder would be issued directly to individual soldiers in their standard first aid kits, a small paper packet of powder for the wound, tablets for oral administration. The instructions were straightforward. If wounded, pour the powder directly into the wound, apply the dressing, take the tablets. No physician required, no hospital. A soldier bleeding in a ditch could administer the first line of defense against infection himself within minutes of being hit. By 1943, this system was standard across Allied forces in every theatre. The early reports from the field were striking. Wound infection rates began to fall in ways that surgeons initially found difficult to explain, until the pattern became undeniable. Men arrived at surgical units with wounds that had not yet turned septic. Operations requiring amputation were being performed with the limb intact. Medical officers filed reports with language that, for military documentation, was unusually direct in its optimism. The powder worked. The tablets worked. Soldiers who should have died were surviving. That certainty would not last. To understand what sulfonamides did to the mathematics of military medicine, it helps to understand what came before. In the First World War, wound infection had been catastrophic. Gas gangrene killed tens of thousands of men who had survived their initial injuries. Surgeons responded with aggressive debridement and antiseptic irrigation that damaged healthy tissue alongside the bacteria it was meant to kill. A substantial proportion of soldiers who died in that war died not from their wounds but from what grew in them afterward. Sulfonamides changed that calculation. American Army medical reports from the North African theatre documented wound infection rates significantly lower than anything achieved in comparable conditions during the previous war. Surgeons who had trained in the 1930s and expected infection as near certainty in abdominal and extremity wounds were operating in an environment where that expectation no longer held. The impact extended beyond wound care. Sulfonamides controlled bacterial pneumonia, reduced the spread of meningococcal meningitis through military encampments, and measurably reduced gonorrhea's impact on combat readiness. In December 1943, Winston Churchill contracted pneumonia in Carthage. He was treated with sulfadiazine and recovered. Lord Moran documented the treatment in detail. The Prime Minister of Great Britain had been kept alive, at least in part, by the same compound issued to privates in their field kits. At the operational level, the effect was cumulative reduced hospital stays, soldiers returning to duty who would previously have been evacuated permanently, mortality rates for treatable infections falling consistently across every theatre. The results were undeniable, but in the field reports of 1943 and 1944, alongside the successes, something else was beginning to appear. The first signs were easy to dismiss. Severe nausea after sulfa tablets, but the soldier was dehydrated and hadn't eaten in 2 days. Unusual skin discoloration in Pacific patients, but tropical conditions made reactions common. Kidney pain following treatment, but the report was filed alongside hundreds of others, and no pattern was visible yet from any single document. The problem was not that sulfonamides stopped working. The problem was what they did to the body at the same time. The compound was filtered through the renal system, and in conditions of dehydration which described the baseline state of most soldiers in most combat environments, it crystallized. Sulfanilamide crystals forming in the renal tubules caused crystalluria, ranging from mild discomfort to acute renal obstruction. In the worst cases, kidney failure. The instructions were clear. Drink water. But in the field, water was scarce, rationed, or unavailable in the quantities required. Soldiers who had just been wounded, in shock, being moved under fire, they took the tablets because they had been told to. Other complications emerged. Hypersensitivity reactions, rashes and fevers. In rare cases, Stevens-Johnson syndrome. A small percentage showed methemoglobinemia impaired blood oxygen capacity, causing cyanosis and confusion. In soldiers already compromised by blood loss, these effects were amplified. The medical community was not blind. By 1943, clinical literature on sulfonamide toxicity was accumulating. Army medical officers were receiving updates. Some field hospitals had added explicit warnings to their protocols, but the warnings existed alongside the results. And the results were still saving lives at a rate no previous treatment had achieved. The warnings were there. What happened next would make them impossible to ignore. The crisis accumulated. By late 1943, military medical records from multiple theatres showed a pattern that could no longer be explained away. Soldiers were presenting at field hospitals with symptoms sulfonamides were producing rather than treating. In the Pacific, where extreme heat and inadequate water supply created exactly the conditions for crystalluria, renal cases were being tracked separately in weekly medical reports. Men who had applied their sulfa powder and taken their tablets as instructed were developing acute kidney pain within days. Some were passing blood. Some were unable to urinate. A compound issued to prevent them from dying of infection was damaging organs they needed to survive. Dosing proved impossible to control in field conditions. Some soldiers, believing more was better, doubled or tripled their doses. Some medics, working under pressure without adequate supervision, administered amounts that exceeded safe thresholds. A category of casualties emerged that the medical system had not anticipated. Soldiers harmed not by the enemy but by the medicine given to protect them. There were also failures in application. Sulfanimides were effective against streptococcal and staphylococcal infections, against certain pneumonias, but they could not touch gram-negative bacteria, anaerobic species, or the resistant strains beginning to emerge in bacterial populations exposed to widespread sulfonamide use. Soldiers told the powder would protect their wounds were sometimes protected, and sometimes they were not, and neither they nor their medics initially understood why. The cost of getting it wrong was being paid one soldier at a time. The story of sulfonamides, as told during the war, was a story of triumph. Military communications emphasized the successes. Commanders spoke of infection rates brought under control, of soldiers returning to duty who would previously have been evacuated permanently. The sulfa packet was described as one of the war's great medical achievements, a small, portable miracle. That description was not entirely false, but the version told at the time omitted the complications almost entirely. Post-war analysis of military medical data confirms that sulfonamide toxicity was significantly underreported during the conflict. Medical officers operating under institutional pressure to maintain confidence in standard-issue equipment were not always positioned to file reports that called that equipment into question. Adverse reactions documented at the field level did not always reach the aggregate reports that shaped policy. The assumption that soldiers could self-administer a pharmacologically active compound in field conditions without medical supervision, without reliable water access, without the ability to distinguish between infections sulfonamides could treat and those they could not, was never adequately tested before deployment. It was an operational decision made under wartime necessity, and it was not wrong, but it was incomplete. The myth of the infallible sulfa packet persists in popular military history. The reality is that it was a powerful, genuinely revolutionary tool that caused harm alongside the good it did. The renal failure cases were real. The resistance emerging in bacterial populations was real, with consequences extending far beyond the war itself. What the record shows most clearly, sulfonamides worked within limits, not fully understood when they were deployed, and not fully acknowledged until long after the war was over. The shift began before the war ended. When penicillin became available to Allied military hospitals in meaningful quantities in 1943, the relationship with sulfonamides changed almost immediately. Penicillin was bactericidal rather than bacteriostatic. It killed bacteria directly rather than simply preventing reproduction. It carried no renal toxicity. It worked in cases where sulfonamides had failed. By 1944, internal Army medical reports were recommending penicillin as the preferred treatment for certain infection categories, with sulfonamides as a secondary option. The evidence on sulfonamide toxicity was simultaneously being compiled with more rigor than had been possible during active combat. Post-operational reviews assembled the fragmented field data into a clearer picture. The renal cases were counted, the resistance patterns documented. The cases where sulfonamides had been administered to infections they could not treat were recorded. Military medicine revised its protocols. Dosing guidelines were tightened. Indications for sulfonamide use were narrowed to infections where efficacy evidence was strongest. The principle of issuing pharmacologically active compounds for self-administration in the field was subjected to scrutiny it had never received before. The turn had been made, but what it left behind would take far longer to reckon with. The legacy of sulfonamides resists the clean conclusion that commemorative histories prefer. They were the first class of drugs to demonstrate that systemic bacterial infection could be treated with a synthetic compound, that medicine could intervene at the molecular level and change the outcome. That principle, confirmed in field hospitals from Tunis to Guadalcanal, is the foundation on which all subsequent antibiotic medicine rests. The specific lessons of their military deployment shaped antibiotic doctrine for decades. The renal toxicity cases, the resistance patterns, the failures of self-administration in field conditions all absorbed into protocols that made subsequent deployments safer. The assumption that a drug could be handed to an untrained person in a crisis and reliably administered without supervision was challenged, documented, and permanently qualified. Sulfonamides themselves did not disappear. Trimethoprim sulfamethoxazole, a sulfonamide derivative, remains a frontline treatment for certain infections today. The molecule DOMAG, identified in 1932, is still working. In December 1943, a physician in Carthage administered sulfadiazine to the Prime Minister of Great Britain, and Churchill survived. In the same month, in the same theatre, soldiers with damaged kidneys were being evacuated from the front lines, their records noting complications from the same compound. Both of those things were true at the same time. That is what sulfonamides left behind. The war ended, the powder remained.